questions and answers. And I'm very happy to answer your guys' questions at the end. So I do have to just say two things beforehand. Number one, I apologize in advance if my dog Cleo gets in the way of things. She really likes to bark at any animals that happen to be passing by outside. And second off, even though I'm in a very technologically advanced field, sometimes technology and I don't get along as well. We probably get along as well as two people who are going to be debating on TV later tonight. So I apologize for any technical errors. So before getting into the details, I thought it would be helpful to just provide an overview of what I hope to discuss today. Starting off, I'd like to discuss the basics of radiation therapy, which we also call radiotherapy. And throughout this presentation, you'll see that I use the abbreviation RT when referring to radiation therapy. Next, I'll talk about MRI-guided radiation therapy specifically, and then focus in on the use of MRI-guided radiation treatment for pancreatic cancer. Then at the very end of the presentation, of course, like I said earlier, we'd reserve some time for questions as well as answers. So moving on ahead into the basics of radiation therapy. Oftentimes when I meet with a patient, one of the first questions that I'll get is, what is radiation? I think that when we see or hear that word, our minds can go to the worst possible places. We think about subjects like the atomic bomb. We think about incidents like Chernobyl. So I think it's important to take a step back. And when I'm talking about radiation, what I mean by radiation itself is the transmission or the movement of energy through a medium, something like air, water, or in the case of radiation therapy, the human body. This energy itself is capable of breaking bonds, so the connections between atoms, or it can alternatively simply just move through and transfer that energy without causing any kind of damage. When I say radiation therapy, which is bolded here, I'm specifically referring to the use of high energy radiation to shrink tumors or to kill cancer cells. There are different ways for us to deliver this radiation treatment. And generally, when I'm referring to radiation treatment, like 99% of the time, I'm referring to external beam radiation treatment, which is basically the use of a high energy X-ray that's focused on a tumor with the goal of zapping that tumor away. We also do internal forms of radiation therapy as well, and that's something that's called brachytherapy, but I won't talk about that as much today, primarily because we don't use it as frequently when it comes to pancreatic cancer. To give you a sense of where we operate, this picture here illustrates just different forms of radiation, and they range from things like radio waves to microwaves, all the way on over to X-rays and gamma rays. And this red rectangle here is included because it highlights the fact that I'm specifically concentrated over on this right-hand side, and that I utilize these X-rays and these gamma rays to treat individuals. These forms of radiation are very high energy, and these are very specifically the kinds that we use. But I think this diagram does a good job of representing the fact that there's different forms of quote unquote radiation all around us. After I tell folks what radiation is, the follow-up question tends to be, how does it work? The X-rays tend to work on the DNA of cancer cells. So this picture here is an illustration of the DNA, the genetic material that we have inside of our bodies. And the way that the X-rays work is that cancer cells, unlike the other cells that we have in our body, aren't able to do a great job of repairing damage. So the only things that cancer cells really know how to do are to grow, and we take advantage of that weakness. When a cancer cell's DNA is damaged by radiation, basically this wave here that's coming in and causing damage to the DNA, what we see is that the cancer cell will still try to grow, it'll still try to divide, but when it gets partway through the process and it recognizes that its DNA is damaged, it can't really do anything about it, and it gets stuck in something called mitotic catastrophe. The name, of course, doesn't really matter as much as the fact that when the cancer cell pauses like that and when it gets stuck, it can't do anything else and it slowly dies off. And our body's immune cells and inflammatory cells come in and eat away, get rid of that tissue. And now that you guys have a decent idea of just what radiation is, I think it's important to know that we can use radiation treatment in several different ways. A lot of my patients, or a lot of our patients, think that we only get involved towards the end of a patient's course of care when incorporating something like palliative radiation, which is treatments that are done to either relieve or hopefully prevent symptoms associated with an advanced cancer. And these can include radiation treatments to help with things like pain, to help to improve breathing, and to help to stop things like bleeding. But I will say that the majority of individuals that I see have curable cancers and treat many folks with curative intent or definitive intent radiation treatment. We can also use radiation treatment in different kinds of settings, such as after surgery or before surgery. When we deliver it after surgery, it's usually done with the goal of decreasing the chance of the cancer coming back. And when we deliver it before surgery, it's supposed to help to shrink the tumor to help to make somebody a better candidate for surgery. And this is oftentimes what we'll actually do with pancreatic cancer. We can also use radiation at lower doses in combination with other kinds of treatments like chemotherapy, immunotherapy, or other targeted therapies that my colleagues in medical oncology will prescribe. We know that about half of all cancer patients, at some point over the course of their diagnosis and at some point over the course of their treatment, will eventually receive some form of radiation treatment. In terms of some of the basics and the logistics about radiation, I tell my patients that getting a radiation treatment is an awful lot like getting an X-ray. Generally, these treatments are painless, and we usually schedule them so that they're delivered on a daily basis, Monday through Friday, for anywhere from 1 to 10 weeks. I'll joke with my patients often. I feel like my colleagues in surgical oncology and medical oncology make this joke too. You guys don't need to come in on the weekends for radiation treatment because your radiation doctors are not coming in on the weekends either. We get our weekends off too. When we deliver these radiation treatments, they can be delivered in many different kinds of regimens. So I say here that the dose fractionation can be variable. And that's basically getting at the fact that we can deliver different kinds of prescription doses of radiation treatment. And this fractionation refers to the schedule. We can deliver them daily. We can deliver them any other day or every other day. It just depends on the kind of cancer that we're treating. And sometimes we can even deliver treatment in as short of a course as a single treatment. And this actually becomes quite relevant later on because when thinking about pancreatic cancer, I think all of us know that that cancer itself can be one of the most painful cancers out there, just because of the fact that it does a frustratingly good job of invading into the nerves in the very center of the body. And there's actually even evolving data. There's research that's showing that we can use single high doses of radiation treatment to help with pain associated with pancreatic cancer, with patients as many as 60 to 80% of them reporting significant improvement in pain. In terms of thinking about the side effects of radiation treatment, tell my patients that the side effects are cumulative, meaning that they build up over time as the radiation dose builds up. Generally, many of these side effects either resolve or they improve within about 4 to 6 weeks of finishing up radiation treatment. But of course, we maintain very close follow-up of our patients because we recognize that everybody heals up differently. And we also recognize that just based off of individuals' different sensitivities to these different kinds of treatments, that some other side effects, these late toxicities, can make themselves known down the road. And we, of course, help with the management of those too. When thinking about other basics of radiation treatment, I think it's important to establish that we follow a pretty standard workflow. And illustrated in this slide here is our general workflow for radiation treatment. For the most traditional courses of radiation treatment, generally we're able to get folks set up and ready to go with radiation treatment within just a couple of days. And there's different procedures that are involved with this process, and I have them listed out here: simulation, planning, QA, and delivery. But I think I'm going to actually skip past this slide just to talk about each of these separate elements first. Simulation. When I use the word simulation, another good phrase for it is a planning session. It's almost like a dry run at the radiation treatments themselves. When I bring a patient in for simulation, I'll generally set them up on a CT scanner, as you can see in this picture here. And they're set up in the position in which they'll get treated, and we get a very short CT scan. I recognize that nearly all of our patients who come to us have been through different imaging studies, but part of the reason that we repeat one of these scans in our department is because our scanners are electronically connected to our radiation treatment machines. So we're able to utilize those images to directly plan out the radiation treatment. We also make devices at the same time that will help to make sure that a patient's set up in the same position from day to day to try to help make sure that the x-rays are as precise as possible and are always targeting the right spots. We'll typically also give our patients some tattoos that serve as reference marks, and they're almost like crosshairs of sorts to help to make sure that we're always lining our patients upright to make sure that our treatments are as precise as possible. Oftentimes too, I'll typically link together my imaging with the other scans that my patients have gone through to best help me to determine what area of the body specifically to treat, and to best help me to determine how to plan out the radiation treatment. On this slide itself, you can see an example of an individual with a brain cancer who's being set up for radiation treatment. They're laying down flat on the CT scanner, and you can make out this mask here that people can see through, people can breathe through, but the rigidity of that mask helps us to make sure that our patients won't move around during radiation treatment, helps us to minimize any of that wiggling around, just so that the x-rays can be as precise as possible when we're delivering treatment. The way that I describe this to my patients is that it's as if I want to measure 100 times before I cut once, because I want to try to be as precise as possible. After we get that planning session done, the next step in terms of putting together the treatment plan is the actual treatment planning itself. We take the CT scan from that planning session and we literally draw out the target, meaning that I draw out the area on the CT scan that I'm planning on treating, but I also draw out everything else that's sitting next to it. When thinking about a pancreatic cancer, I'm going to be drawing out the stomach. I'm going to be drawing out the intestines, the liver, the kidneys, everything that I want to protect from the effects of radiation treatment. We'll then utilize fancy computer programs with specific algorithms in place to design these radiation treatment plans to help to best deliver that X-ray dose to the tumor while minimizing the radiation dose to everything else nearby. And the goal of that is to maximize the effectiveness while minimizing side effects from radiation. This whole process takes a couple of days, anywhere from 1 day all the way up to 5 to 6 days. And once we're done putting together the radiation treatment plan, some of my colleagues, we work with a whole host of medical physicists, will take this plan and they'll do some double checks and quality assurance to ensure that that plan is safe for delivery. And then once we're ready to go with the actual treatments itself, the machine that we'll utilize for radiation treatment is something called a linear accelerator. And these are two different pictures here that illustrate a linear accelerator. The diagram on the right-hand side, you can see an example of an individual sitting on this linear accelerator, which can be abbreviated to a LINAC. And in this picture in the middle, you can actually even see that the X-ray itself comes out from the top of the machine. So the top of the machine there, analogous to the top of the machine over here. And in this photo, you can see that the X-ray is actually being shaped to a specific shape. It's almost as if the X-ray is shaped to the, oh, we skipped ahead here, sorry about that, to shape to the tumor inside of the body to make sure that the treatments are as precise as possible. I also work with other members of our team, radiation therapists. And radiation therapists, such as this individual here, are the people who my patients get to know probably the best over the course of radiation treatment, because our radiation therapists are the ones who are setting up our patients on the machine themselves, making sure that everything gets lined up right. And they're the ones who, after they get the approval from us, are actually pushing the button to turn on the X-ray itself. Each of these treatments with this conventional form of radiation treatment is typically about 10 to 15 minutes long. And generally over the course of treatments, I check in with my patients weekly just to make sure that everything is going smoothly and to make sure that we're addressing any side effects that may pop up along the way. So now with that description of each of these elements of the timeline for radiation therapy, hopefully you guys have a better sense of just what to expect out of a course of quote unquote traditional radiation treatments. With that good understanding of the standard radiation, I think I can better transition then into discussing MRI-guided radiation therapy, which is the next part of this presentation. In those prior slides, I feel like you guys heard me say a lot that we use CT scans for treatment planning, and I discussed treatments on our CT-based radiation machines. And as the name itself suggests, MRI-guided radiation treatment refers to radiation treatments that, in contrast, rely on the use of an MRI for both planning out the treatment itself, as well as for delivering the treatment. Our MRI guided radiation machines, and this is a picture of one of those MRI guided machines, actually the one that we have within Providence, Portland, the one that we have within the Providence Cancer Institute. The nice thing about these machines is that they actually combine a diagnostic MRI with one of those linear accelerators, with one of those radiation treatment machines, so that we're able to deliver radiation while also using a real-time MRI to continuously monitor the treatment. Knowing all of that, I think a big question that comes up is, well, why should we use MRI guided treatment? It does not escape me that MRI machines, as I'm sure many of you know, are very different than CT scanners. The tubes are more narrow, as illustrated in this diagram here, and that can cause problems like claustrophobia or fear of small spaces. And you also have to generally be on an MRI machine for a longer period of time compared to the amount of time that folks spend on the CT scanner, which can add to anxiety and also discomfort. I mean, I even remember back as a resident when our teams were actually first designing these machines and setting them up, we did trial runs in which I sat in a MRI tube for about 1.5 to 2 hours and experienced all the shoulder pain and back pain that came along with it. So even though there's some potential negatives to being in an MRI machine, there are a lot more positives, and I think that the next couple of slides will do a good job of explaining and showing just why I'll sometimes prefer MRI guided treatment. One of those reasons, and then really reason number one, is the actual picture and its quality itself. When I use a MRI, and this is a picture of a MRI of the chest and upper abdomen on the right, compared to a picture of a CT scan on the left, I think all of you can appreciate that with the MRI, we're able to get better details, better resolution within, say, the liver, which is this structure here, compared to over here, in which everything admittedly kind of just looks like it's shades of gray. We're also able to better see structures like the heart here. You can actually even make out the smaller chambers within the heart, whereas again, here it just looks like black and white. You're able to make out the stomach markedly better, which over here just fades into the background. So when we have MRI scans that we use to set folks up for both treatment planning, for treatment delivery, we're literally able to see the organs, we're literally able to see the tumors better, which leads to better targeting of the tumor and also leads to fewer side effects along the way. Another big benefit of using the MRI machine has to do with its with the real-time aspect of it. With having a continuous MRI running in the background, we can track a tumor in real time. Taking a step back for a second, we know there's studies that have been done that have shown that when we take a deep breath in, everything in the body moves around, and stuff within the abdomen, like the liver, the pancreas, can move as much as 2 inches. When I treat a patient, I want the X-ray treatments to be as precise as possible. So that kind of movement can really raise my anxiety and give me pause, give me concern as to whether we're actually treating the right spot. But with the real-time MRI, I'm able to watch the tumor and make sure that the X-ray only turns on when the tumor's in the right position. And this kind of an approach, this kind of tumor tracking or gating, is illustrated in this diagram over here. When the tumor's out of this pre-specified boundary, when it moves out of this area here, the beam actually turns off. But when somebody takes a breath in, when the tumor moves back in to the spot, this boundary where it's supposed to be, the beam turns on. And it helps to make sure that when we're delivering radiation treatment, we're delivering it at precisely the right time. And that's something that nowadays we can really accomplish best with use of machines like our MRI guided machines, simply because we have that real-time tracking available. And this slide here, I recognize that it's pretty messy, but I think after we talk about it a bit, it will make more sense. Just like I was saying before, when we treat tumors, we know that they move around a lot, but so do the organs nearby. I also recognize that as we're delivering those X-ray treatments, as we're killing off those cancer cells by causing inflammation and whatnot, that these tumors can shrink in size, or with the inflammation, they can even falsely appear to be a little bit bigger during radiation. And when we design our initial radiation plans based off of that planning session, they're based off the tumor appearance, they're based off the nearby organ appearance at the time of that planning scan. So unfortunately, our plans don't always match up with how the tumor may look on any given day. And one of the great things about the MRI machine is that with our workflow, we're able to get a fresh MRI on each treatment day. And I'm able to look at those changes on a daily basis. As a result, I can notice if there's any major changes in terms of the size or in terms of the appearance. And accordingly, I can replan the radiation treatment, or I can adapt the radiation treatment on a daily basis to make it a safer and a more effective plan. This picture on the right does a really good job of illustrating that. This was from treatment of a spot of tumor at the top of the liver, which is this structure that's outlined in yellow. The tumor here is this orange line in the middle. This other stuff that you see nearby, like this structure right here in the center, is the esophagus. That's the heart. The lungs are surrounding it. Spinal cord is back there, all showing that the tumor is right next to a whole bunch of very valuable and important real estate. And what I was able to do with this specific radiation treatment is that I noticed that that day the esophagus was actually inching a little bit closer towards the tumor. The heart was also closer nearby too, just based off of the anatomy. And what I was able to do with the plan is I was almost able to resculpt and reshape the radiation dose so that it was able to stay off of those organs nearby while still providing really good prescription dose radiation treatment to the tumor, basically getting the biggest positive out of it in terms of tumor killing effects, while also helping to limit the biggest negative side effects from radiation treatment. And this kind of adaptive radiation treatment, it was actually first designed with these MRI-guided radiation machines. So almost as a summary of sorts, with MRI-guided treatments, I'm able to just overall achieve a lot more, including a better ability to visualize the tumor and the nearby organs for treatment planning, the ability to track the tumor during treatment and turn off the X-ray if it looks like the tumor is moving too far away. And then finally, the ability to adapt treatments, to modify that plan on a daily basis to help to make the treatments safer and more effective. So now with that kind of insight of sorts into the benefits of MRI-guided radiation treatment, I think we can now steer the conversation specifically towards pancreatic cancer. Unfortunately, I think many, if not all of us, know and love somebody who's been affected by this terrible disease process. Pancreatic cancers are notorious because oftentimes by the point that they start to cause symptoms, they've grown in size and are difficult to manage because they sit so close to so many important organs like the stomach, like the liver, like the gut. We've made a lot of strides overall with different kinds of cancers, but I think we can all recognize that we have room for improvement very specifically with pancreatic cancer. At this time, the overall 5-year survival for pancreatic cancer is about 12 to 13%. And what that means is that for every 100 people diagnosed with pancreatic cancer, 5 years out, only 12 or 13 of them will still be alive. The main curative therapy option from the prior studies that have been done from our prior experiences with pancreatic cancer, we know the main curative option is surgery. And I think last year or 2 years ago, one of my colleagues, Dr. Badicki, may have spoken with your group about surgery for pancreatic cancer. Unfortunately, only about 15 to 20% of people will have localized disease, meaning that the disease hasn't metastasized, hasn't spread to other areas within the body. And even for folks with localized disease, sometimes the disease is still too advanced to be able to do surgery. And unfortunately, the 5-year survival rate, even for localized disease, is still overall pretty low, especially compared to other cancers out there. And I think that all of this demonstrates the need for better treatments. So you guys already saw this slide, but one of those treatments could indeed be radiation, particularly with MRI-guided radiation. In a lot of ways, pancreatic cancer really is the poster child for MRI-guided treatments, especially when we think about those potential benefits that I talked about earlier and are summarized here. Thinking about these three big benefits, I think we can briefly talk about them each separately and specifically for pancreatic cancer. For example, starting off with visualization. Using the MRI-guided radiation machine, we can literally see the tumor in the intestines so much better compared to using a CT scan. On the left-hand side here is an example of a planning CT scan. And I think that everybody can appreciate, almost akin to that picture that I had shown before, that it is very difficult to discern, very difficult to separate out the structures from one another. Like, for example, this here all kind of just looks like a big old gray blob, but that's very different compared to, say, the planning scan from the MRI machine, in which I think we can all appreciate that the intestine, this part of the intestine called the duodenum, you can actually make out it looks completely different compared to that darker, sorry, technology again, compared to that darker ball here in the center. Basically, this MRI here is showing that we can do a much better job with distinguishing the tumors from the organs nearby. And that helps out a heck of a lot in terms of planning out the radiation treatment. I had also discussed tumor tracking beforehand, and I have a video here in which the tumor is actually a focus of pancreatic cancer that had spread to the liver in one of my patients. Lovely patient who had a single site of metastatic disease within the liver itself, no other evidence of any other cancer elsewhere. For whom her options were either to continue with more chemotherapy or to try undergoing this ablative, meaning this tumor killing form of radiation treatment. When she was sent on over to me by my colleagues, I felt pretty strongly about putting her on my MRI guided machine. And just to help to explain the picture a little bit, you can see this red circle here is actually the tumor that's outlined. And this yellow circle is a boundary of sorts, almost like a window in which the x-ray will stay on if the tumor's inside of it. And I'm going to start playing this video here, and hopefully, fingers crossed, technology works. Perfect. Looks like it's going. So you can see here in real time that when my patient here takes a breath in, when the lungs expand, when the liver moves down, that red circle moved out of the yellow circle. And at that time, you can see in the lower left-hand corner that when the red circle is out, it literally tells me that the beam is off. But when the red circle is within the yellow circle, the beam is on. So this is a really good example of use of the real-time MRI, the real-time diagnostic MRI, to help us out with radiation treatment. And ultimately, I think this kind of an approach helps us to best target the x-rays on the tumor. And finally, this picture here is a really good illustration of our ability to adapt or to modify the radiation treatment plan over the course of treatments. This first picture here is the radiation plan from the first treatment, while this picture here on the right is the plan from the last treatment. The tumor's outlined in orange here in the center. And I think that you can appreciate that the size of it, the shape of it has changed over the course of treatment. And similarly, the location, the size, the shape of other nearby organs has also changed. And those are shaded in other colors, especially the liver here, which is shaded in this pink or purple color. Obviously, I should have had a better Crayola box growing up because I don't know quite what shade of purple that is. Anyway, given these changes, we're able to use our MRI guided machine to basically replan the radiation treatment plan. You can see these this rainbow of colors here in circles that are corresponding to the high dose radiation in red versus the low dose radiation in blue. And you can see that based off of those organs nearby, we basically reshaped the radiation treatment plan to better accommodate itself to just the anatomy for the day and how things happen to appear that day. There is a trade-off of sorts when we do MRI-guided treatment because it is such a labor-intensive process and in a lot of ways a specialized procedure. I tell my patients that treatment on the MRI machine will generally take longer. We spend more time, for example, during the simulation or during that planning session, just to help to make sure that I have the best possible MRI, the best resolution, literally the best picture for planning out the radiation treatment. Because there's a lot more considerations when it comes to treatment planning. It takes longer for my dosimetry, the team that I work with, to actually put together the radiation plan. It takes longer for them to plan out these treatments. The quality assurance process is still pretty similar between the two because of the checks that our medical physicists do. But then the treatments themselves can range from anywhere from 30 minutes all the way to 2 hours for treatment. I will say that with the high specificity, with the precision that I'm able to provide with the MRI guided machine, we're generally able to deliver a relatively high dose per treatment. So we're able to do shorter courses of treatment and still treat folks to the most appropriate or prescription dose. So for many of my patients on the MRI guided radiation treatment machine, I'll usually limit treatments to 5 treatments. And that's based off of really good data from other institutions, data that the Providence Cancer Institute has also published on. Even though there's those trade-offs when it comes to timing, I think that one of the biggest reasons that I'm so enthusiastic about using MRI-guided radiation therapy for pancreatic cancer is because we literally have data from trials that have shown that incorporating this kind of treatment improves outcomes for folks with this terrible disease. The SMART trial, stereotactic MR-guided adaptive radiation therapy trial, which is, I mean, in medicine, we always have just these terrible, I think the doctors think they're being funny, but they're just these terrible names for trials. I remember actually sitting in a room as a resident as they came up with the name for this trial. But this trial actually evaluated the use of MRI-guided radiation treatment and adaptive MRI-guided treatment for individuals with localized pancreatic cancer. And it included folks who were either candidates for surgery or who were not candidates for surgery, folks who had locally advanced pancreatic cancer. And compared to the outcomes that we're used to seeing, compared to say the historical standards, the numbers that have been published beforehand, we saw that 2-year survival darn near doubled from about 20% all the way up to 40%, with really a minimal number of side effects and minimal number of complications for folks undergoing this kind of radiation treatment. And I think that those are outcomes, those are numbers that are very, very difficult to argue against. I think that this improvement in survival can pretty reasonably be balanced against some of the side effects associated with treatments. When I'm meeting with somebody with pancreatic cancer, I'm meeting with a family member, I tell my patients and their families that during radiation, I can cause some irritation to the stomach or some irritation to the gut that in the short term can cause just irritating symptoms like nausea and vomiting or some mild diarrhea. It is pretty common too for my patients to experience some fatigue. It's almost as if I'm zapping the energy out of them, and that I recognize is a terrible pun to use, and I'm pretty guilty of using it all the time. Usually these early side effects improve within about a month or so of finishing up radiation treatment, but I'm always on the lookout too for any late side effects of radiation treatment as well, which thankfully are far more rare. Some of these potential side effects are listed here on the right, stuff including risks like ulcers with bleeding. But thankfully, with incorporating those MRI-guided radiation treatments with better sparing of the organs nearby, with better protection of those organs nearby, we're better able to minimize those long-term risks too. We also have ongoing clinical trials here within the Cancer Institute that have evaluated the use of MRI-guided radiation treatment and other potential therapies that we can incorporate. For example, this SMART trial here that was published on relatively recently. So the article is from February of 2024. The Providence Cancer Institute was actually one of the institutions that provided or offered the SMART trial to patients. And we also just recently finished enrolling patients on an international multi-institutional trial evaluating the use of these adaptive radiation treatments with or without the use of a radiosensitizer, which are medicines that help to make tumors more sensitive to the effects of radiation treatment here. And that schema or that approach is illustrated here. We did these radiation treatments either with or without that radiosensitizer, and I think all of us are eagerly awaiting the results of that trial. Given these trials, these new approaches and the advancements in therapy with MRI-guided radiation treatment, I remain very optimistic for the future. It does not escape me that pancreatic cancer is a terrible disease, but my patients with pancreatic cancer continue to inspire me on a daily basis to continue this work and to continue to fight to provide the best potential care that I can. Admittedly, I see patients from all over the Pacific Northwest, as our MRI-guided machine has historically been the only MRI-guided machine available in the region. There's more institutes, there's more hospitals that are investing in this technology now, which is very exciting to see, because I think all of us within radiation oncology, all of us within medicine, and all of us who have family members or friends who have been affected by this just want people to do better and want people to have better outcomes. If you, friends or family, ever have any questions about whether you or a loved one would be a candidate for these treatments, I always encourage you to reach out, and our contact information is listed here and will be provided to you guys at the end of the presentation. And on that note, for the final part of this presentation, I did want to reserve some time for questions and answers. So I think for now, I'm largely done speaking, but I'm happy to answer any questions.
And on that note, I will go ahead and stop recording so that folks are not concerned about any kind of personal information being recorded here if you ask a question.